that they serve. So this came from California, this schematic, and I'm not going to stay on it very long, but I think just to let you see this, when we talk about the journey that we've been on for 5 years, you can see we started with Medicaid and clinical services. And one of the reasons we say kind of, maybe a little sarcastically, that we could bring all of our payers and providers together around Medicaid transformation and reform, because everybody was losing money on it. And it was a problem for our legislators, it was a problem for our health systems, it was a problem for our payers. So it really brought everybody to the table and say, well, the best we can do is like lose less money, but we're really seeing really good results over time to show that we have actually increased quality, increased care, and also turn down the cost drivers that we see across the state. But where do we want to go? That's just where we started, over there in that green circle. Right now, we are struggling, and you'll hear some stories in that blue circle. Like, how do we bring all of this together? And then where we really want to go is way over there, integrating health, human services, and have community problem solving, specifically to community areas. And some of the if you look down the side there, the payment models, the incentives, these are some of the things that we're experimenting with and driving with to see how we can get to that last circle, the community, the real community driving areas. So let's see. So I'm just going to end with this little slide here to talk a little bit about, these are the areas in our, Dr. Wolf talked about contextual factors. So before we get to keeping kids in school, we got to figure out how do we get them to school. And these are the areas that we've been working on together as a state with common variables and trying to get to common outcomes that we can all say, what does each of this, what do all these sectors contribute to get to healthy Oregonians and kindergarten readiness? We're looking forward. We'll continue to pursue these opportunities. Our approach in the future is even finding more and more less traditional partners. I really appreciated one of the earlier panels saying, how do we sustain this? We've tried to do on the state level memorandums of understanding. So if the Celestial bus comes around the corner for me on the way home, it's not just about the health department director with, whatever, Department of Transportation, Department of Environmental Quality, but we have memorandums of understanding that have been sanctioned by our governor and our legislature between these agencies. So the Oregon approach includes focus on relationships, formalize agreements, target initiatives, and track progress through metrics, incentives that all reflect this cross-sector accountability. So I'm going to stop there so we can get into the real meat of why we're here to hear the stories of these struggles. Thank you for your time and attention, and thank you for inviting Oregon.
So I'm going to take a slightly different track to the conversation for this morning. I actually have no PowerPoint slides, so put up your prop. So I'm going to explain to you how a Medicaid managed care plan ended up in the school success space, and a little bit about our journey and where we're at today. So as Lillian mentioned, we started in 2012, and my board's first assignment was to go out and find the high utilizers and fix them. Actually had somebody say that to me. I was pretty sure that's not how it worked, but I said, okay. And so find the high utilizers and earn the metrics. In Oregon, we have quality incentive metrics that bring in a lot of money. It's bonus money to the Medicaid system. This year, HealthShare will probably earn a little over $45 million in incentive metrics. So we were chasing the high utilizers, and we were chasing these incentive metrics, and what we quickly learned was if you really started looking under the hood of the high utilizer population, what you found was a socially constructed pathway to high utilization. Their life of trauma, a life of adverse events had really led them there. And increasingly, my medical director at the time kept saying, Janet, we have to do kindergarten readiness. We have to get upstream. We have to get upstream. And I kept saying, no, we're a Medicaid plan. That's not our business. That's the school systems. That's somebody else's problem. Meanwhile, we were chasing these metrics, and a lot of the metrics were about kids. There was developmental screening, adolescent well visits, screening for kids in foster care. And we were chasing the metrics and getting the money and checking the boxes. And we started to think, what happens to these kids after they get screened? Where do they go if they need help? And literally took out crayons and paper and started mapping out and realized we had much more work to do. Right now we have about 320,000 enrollees. We're the largest coordinated care organization in the state. About 1.9 billion in revenue. Now remember, Oregon's a very small state in population, and we're a third of the Medicaid expense in Oregon, and we're almost at 2 billion. That's a lot of money. Our operating revenue is around 1.5 billion. Just a tiny amount from that global budget can make a big difference in the community and in agencies that we work with. We started on after we realized that we weren't going to be able to fix the high utilizers, we started to put our toe into early life health, and we really didn't know what we were doing. It was not a comfortable space for us. We're healthcare people. That's what we do. We started collaborating with agencies who basically said to us, where have you been? Did you not realize you were in the early life health space? And we started sitting down and really thinking through the impact we could have. If any Medicaid managed care plan says they're not in kindergarten readiness, they're fooling themselves. Every year, our health plan alone produces about 400 kindergarten classes every year. So 400 future kindergarten classes are birthed. Actually, it's a little bit more than that now. Are birthed out of our plan every year. The healthcare system is the one social system that touches these kids consistently until age 5. So as we started looking at the data and really thinking about things, we started dabbling. We started with bringing a program called Project ECHO to Oregon. Project ECHO is a telementoring program that tries to upskill providers. We focused our Project ECHO on upskilling pediatricians and other child age providers to handle those kids that don't need developmental pediatrics. You know, we have a shortage of developmental pediatrics, and trying to upskill them to help them in the practice care for those kids. We funded a 3-year investment in Help Me Grow to launch it for the entire state. Help Me Grow is a well-known program that helps vulnerable kids and their families get connected to services. And we found that we were starting to get some traction on that. And it started to feel like that really was the space we were supposed to be in. Fortunately, in the fall of 2017, our board of directors approved our current plan, which is called Ready and Resilient. The ready part is start strong, getting kids ready for kindergarten and getting families connected to the resources they need to be successful. The resilient part is really about supporting recovery. Mental health and addictions burden is very toxic to families, and it really affects our kiddos. So we're focused on start strong, support recovery, and then share health, which is our overall equity and disparities lens that we use. We're focused right now on collective impact. Took a few years to build it out, but we've got it up and running on kindergarten readiness, working with the early learning hubs, working with community-based organizations, learning how to work together. Remember, it takes a very little amount of money to fuel these things. We are partnering on our kindergarten readiness collective impact with United Way and social venture partners. We're all funding it together. We're focused a lot on screening and referrals, and our screening starts with what we call before 9 to 5. So it's effective contraceptive use up to kindergarten readiness. That's the scope of our sort of strategic space we're in. Effective contraceptive use also happens to be a metric that we're chasing. So again, we're able to tie all of these things together. Screening and referrals to services, and then another special population focus, particularly around women who are substance users and are pregnant, and then around kids that are in foster care, which we know have really difficult health outcomes. So how did we convince the board to go in this space? Well, I wish I could tell you it was magic and we just sort of threw the pixie dust out and they got enlightened. That wasn't quite it. It was a 6-year conversation. It's still uncomfortable. It's still uncomfortable to make investments in the system of care, and they want to know, well, wait a minute, how many community health workers are we going to get from this investment? It's like, no, we're investing in an infrastructure. You know, we're trying to build out the system of care. So the other struggle we have is the return on investment is not going to come back to us. The return on investment is to the families, to the community, to the taxpayers. both of the United States and the state of Oregon. So that return on investment is very remote for the board. And how we finally got there was we started thinking about Medicaid, not just as a safety net. Medicaid always is going to be a safety net. It has to be. But also thinking about using Medicaid as scaffolding and really talk about what our families need the most is to get out of poverty. And if we can affect kindergarten readiness and help that next generation to avoid becoming a high utilizer and to get out of poverty, then I think that's the right use of Medicaid funding. So that's the CCO story in a nutshell, and I'll turn it over to my partner in rural Oregon.